Himanshu, can we?
Just a second, sir.
Yeah.
So it's 3, 2, 1. We are live with the audience. We can start this meeting. Over to you, sir.
Yeah, good evening, everyone. My name is Nitish Srivastav, and on behalf of McLeod's Pharmaceuticals, I extend a very warm welcome to each one of you who are logged in today evening on a really a good monsoon day for this very appropriate webinar. I'm also thankful to all the panelists. They are of national, rather, I would say international fame for their valuable presence, and they have decided to give their time for this seminar. I'm sure today's discussion will prove very, very valuable to each one of you, and you will certainly be able to get some pearl of wisdom from today's discussion. As an organization, it has always been our endeavor to provide the clinicians a platform where they can discuss and deliberate the current clinical challenges, as well as the points and topics of their similar liking. And today's webinar is one such effort in this direction, the management of allergy and asthma in monsoon. Allergy today, which has become a major menace for each one of you. I'm sure today's discussion will certainly bring a lot of the points to carry home in your day-to-day practice. And thank you once again for your presence. Over to you, Dr. Ashwin.
Thank you, sir. So I welcome you all for this today's webinar, Management of Allergy and Asthma in Monsoon. For this webinar, we have with us very well-known doctors of India, Dr. Sunita Chapula Shukla, allergy specialist. She is the moderator. So I would like to have this opportunity to introduce Dr. Sunita. So ma'am is honorary consultant allergist at KM Hospital, Mumbai. She has trained in advanced allergy from Harvard Medical School, Boston Food Allergy Center, New York, Singapore, and Barcelona. She is recipient of Dr. Henry Klaman Gold Medal Award, Dr. V. Raju Award, and first prize for Best Research Paper, Best Scientific Researcher Award from 7th ASDF Global Awards 2017, and National Mahila Ratan Gold Medal Award. And her core area of interest is allergy. On behalf of McLeod's Pharmaceuticals, ma'am, we welcome you for being a moderator for today's webinar. Over to you, ma'am.
Thank you, Ashwin, and thank you, McLeod's, for this opportunity. The topic is very apt for what is going on nowadays everywhere, monsoon and respiratory allergies. So without much ado, I won't waste time. Let me start with the first speaker, who is a very dear friend of mine, Sarika Verma. She doesn't need any introduction, but still I will do the honors. She is a senior ENT surgeon and allergy specialist from Gurgaon, and she has a chain of allergy clinic called Allergy Doc in 5 cities. She is also the Gurgaon ENT Association president and chairperson of IMA Gurgaon Women Doctors Wing. And she has spent more than 2 decades helping patients with allergic diseases. And apart from this, she is a socialist, philanthropist, and she is working for women's cause and so many other good things which are happening in Gurgaon nowadays. So welcome, Sarika, and over to you.
Thank you very much. It's a pleasure to be here, and I'm thankful to McLeod's for this opportunity. I know everybody is done to death with online webinars after COVID, but considering the paucity of time, where online webinars are a very good way to update your knowledge. And I will just share my screen. Please let me know if you can see it, because then later on it gets troublesome. Can you see my screen, please?
It's coming, ma'am. Yes, it's visible.
Yes?
If
Okay.
you can do the
So
slides mode.
I have about 15 minutes, Doctor. You can just let me know if I'm running short of time, okay? Right, here we go. So allergic rhinitis in monsoons. Allergic rhinitis is, of course, a global phenomenon, and in monsoons it becomes worse. We'll just speak a little bit in detail about how that happens. And what is allergy? because it is a mixed audience of ENTs and non-ENTs, I'm just going to a little basics, but I'll be very brief. Allergy is IgE-mediated hypersensitivity reaction. It's a type 1 reaction. There are 4 kinds of hypersensitivity, but type IgE-mediated is typically led by proteins. So a lot of times you'll see patients saying कि pollution से allergy है, या smoke से allergy है. All of them are pollutants or irritants, but allergy is always a IgE-mediated to a protein. So allergic rhinitis is now a systemic disorder causing inflammation not only in the respiratory passages but the entire body, and chronic airway inflammation may contribute to systemic inflammation as well. And it is through multiple chemicals like cytokines, leukotrienes, but I'm not going to go into details. I'm just going to stick to the clinical aspects. Various kinds of allergies are there: allergic rhinitis, bronchitis, urticaria, foods, drugs, and contact allergens. Allergic rhinitis is typically has 3 or 4 things. One is excessive sneezing, watery nose, nasal blockage, and nasal itching, which may or may not be associated with itching eyes. Of course, everybody knows what asthma is, and then the adenoid hypertrophy, which you see in children a lot, is aggravated by allergies. And chronic rhinosinusitis is a typical mucopurulent discharge, recurrent episodes of sinus headaches, and nasal polyps. All of them have their base in allergies. Allergic cough, which is now we see a lot more post-COVID. I think it is uncapped allergic cough to another level. And angioedema, I see this in a lot of patients nowadays, swelling of the lips or swelling in the eyelids, and urticaria or atopy, and food allergies. So there is something called the allergic march. Ketani et al. Gave the concept in 1990s. So basically what it means is patients with allergies, usually in the first 1 to 5 years of life, they develop atopic dermatitis and food allergies. And then over time, they then convert to respiratory allergies. And then it can, by the time they're in their teens, they get allergic rhinitis. And by the time they're in their 30s, they may develop asthma. So we see this progression, and this is called allergic march. There are various kinds. Sometimes it is bronchitis that then converts to skin allergies. That is called the reverse allergic march. But essentially, as an allergist, the important thing is to stop this progression and stop the patients from becoming asthmatic. Allergic disease is a global public health hazard. As you can see, in the 60s, the incidence was about 10%, and now it is almost 20 to 30%. In fact, some studies say that almost 1/3 of the people have allergic rhinitis. So allergic rhinitis 60%, and prevalence of all allergies is about 70 is allergic. So allergy is a huge problem, and skin allergies are present in about 5% of the population, and various things are responsible for them. India, the prevalence has increased in the last 2 decades. In fact, over the last 4 to 5 decades, the things have not only doubled, they have become 4 times. And or it is allergic rhinitis, as we said, is the inflammatory process of the nasal mucosa. And if you treat the nose, if you treat the sneeze, then you will prevent a wheeze. If you don't treat the nose adequately, then obviously it's going to go into the lower airway. The next lecture will be about asthma, so we'll learn more in detail about that as well. So typically it's allergy. You have excessive sneezing and blocked nose, watery nasal discharge, itching in your nose, and allergic and red eyes. And area classification has, we used to call it seasonal and perennial when we were in college and doing MBBS days. But then area gave this guideline almost 20 years back that you may now classify it into intermittent and persistent. Intermittent is less than 4 days in a week, less than 4 weeks in a year. Persistent is more than 4 days in a week or more than 4 weeks in a year. These are both further classified into mild, moderate, and severe, depending on whether the sleep is disturbed or not, whether the normal activities are disturbed or not. And this is important that when you have a patient in the first 2 minutes, when you make a diagnosis, so always write the diagnosis: intermittent allergic rhinitis, mild, moderate, or severe; persistent allergic rhinitis, mild, moderate, or severe. That helps decide a lot of things for you. So when you find somebody with an allergic rhinitis, so you have to ask them, how did it start? How long they've been having a problem? How much is the medicine requirement? Do they take antihistamines daily or not? Do they need intranasal corticosteroids? Are they taking it regularly? Are they taking inhalers? And are they, in small children, are they taking nebulizers? And overall, what is the impact on the quality of life? All these questions together, they help you reach a diagnosis and your classification. So when we have an allergic rhinitis patient, you must spend a couple of minutes asking these questions for each and every patient, so that we are able to analyze in the first 20 to 30 seconds of interaction, how much is the intervention that we need to do. Is it something very mild and very recent onset? Then you can just give them antihistamines. Is it something that is severe that needs intervention? Then you give them intranasal corticosteroids. And then if they've been having for many years or some, then you need to give them an allergy test. So this will help us decide what you want to do. So a lot of patients will ask you whether there is a family history in, will my children get this? So if no parent has an allergy, there is an incidence of almost 15% chance of developing allergies. If one parent has allergy, almost 20 to 40%. And when both parents have allergies, 60 to 80%. I see this a lot. And I have to counsel the parents that, you know, you give your good things to the child, you give the bad as well. So please don't hit yourself in the head. So differential diagnosis, allergic rhinitis is fairly adequate to understand, and diagnosis is straightforward. In rare cases, you have a non-allergic rhinitis, various syndromes are there, but that is always a diagnosis of exclusion. And once you have a negative skin prick test, then you go into the non-allergic causes. So how do you make a diagnosis? Like we said, detailed history, anti-rhinoscopy, the terminates will be pale, hypertrophied, they may even be mulberry kind, and you look for nasal polyps. If you think that the mucosa is polypoidal, then you can do a diagnostic nasal endoscopy. Always, always, always auscultate the chest. Every ENT surgeon must have the stethoscope, and a part of your finding should be ear, nose, throat, chest. You can never see a patient adequately without seeing the chest. Always auscultate and look for a wheeze. Basic blood workup, this eosinophil counts especially help to rule out eosinophilia, and if there is eosinophilia, you must treat it. I see so many patients with cough who are running around from patient doctor to doctor with high IG counts, but high eosinophil count, but nobody has treated the eosinophilia. So that eosinophilia part must definitely be treated. And allergy test by skin prick method, I'll be speaking to you a little more in detail. Total serum IG, it helps in giving us a rough idea. But a lot of times we have seen patients with a normal IG can also have an allergic disease. Serum specific IG is more accurate, but it's about 50 to 60% accurate. And at least it helps narrow down the list. But, you know, this test is not extremely accurate. Also, it's very costly. Component testing is something that's come up recently. It's available in a few centers in big cities like Delhi and Bombay. But I have not been able to understand the clinical, how it helps my patient, because unless the immunotherapy comes down to components, there's no point just doing the component testing. That's my personal opinion, though I know many people do component testing. So the allergic rhinitis is not an isolated disease. It has other things that can be involved: asthma, atopic dermatitis, conjunctivitis, sinusitis, polyps that we've already spoken. Secondary, it has affects the quality of life. It can cause and aggravate OSA. And in children with otitis media with effusion and adenoid hypertrophy, there is learning and attention impairment. And because of adenoid hypertrophy, there is malocclusion and mouth breathing. So all of these things have to be taken in consideration when you treat an allergic patient. And rhinitis is definitely a risk for asthma. It exacerbates the asthma. It exacerbates the risk of the number of attacks, emergency visits, and the hospitalization, as well as the amount of medicine needed for control. So there are multiple studies are available that allergic rhinitis reduces the quality of life in asthma. So a general overview, when the environment control is very important. And so whenever you do a test, then you have to explain to the patient how you're going to avoid house dust mites, how you're going to avoid pests, are there any animals, and how do you want to avoid them, especially see that they don't sit in your, they don't go into your bedroom. I know people want to sleep with their dogs, but then it's very important, and even cats. But those are very allergenic animals, so their fur is sheds. So we have to advise people when you have to be very gentle about it, because some people treat their animals like their children. So you have to ask them to invest in a vacuum cleaner and ensure that, things get clean so that the allergies don't increase. So environmental control is very important. Pharmacotherapy, of course, is the mainstay of allergic rhinitis. I'll be mentioning. immunotherapy where and when needed. Patient education, in fact, you need to educate the entire family. Today itself, I gave a medical certificate, and because one of the children, he's about 13 years old and he has a cold because of his allergies. He's on, and the school is telling him, no, you can't come to school because you'll infect other people. So I just wrote a note to the school informing them that allergic rhinitis is not an infectious disease. It is not contagious. He's not going to harm anybody, and they have to treat the child with more empathy. I gave it in writing today. So those are things that are important. Allergic rhinitis medical management. So once we do the allergen avoidance, oral antihistamines, intranasal corticosteroids are the mainstay of treatment. Many patients you'll find do not want to take steroids, especially nasal steroids. So you need to do a bit of counseling. Leukotriene receptor antagonists can be added, especially when the lower airway is involved. And then, of course, finally, it is allergen immunotherapy. So intranasal corticosteroids are the drug of choice. And for patients with nasal polyps, before surgery, after surgery, they have to take it lifelong. This is something that you have to instill to every patient. They are safe for long-term use, and they do not cause dependence. There's very little systemic absorption, and they improve all the symptoms of allergic rhinitis. Coming to oral antihistamines, of course, in mild, they alone can be used. And ideally, you should try to use the least sedative form. Bilastine, fexofenadine, loratadine are all three molecules that I like very much, because most of them do not cause sedation. But you will find that once in a while, you'll have a patient who will say that, isko leke bahut neend aati hai. So you have to find a medicine that suits your patient the best. And cetirizine is safest in children, but of course, it causes a lot of sedation. Because this webinar is, it's for a certain brand of McLeod, so I'm just going to take 1 or 2 slides on bilastine. It's a second generation H1 receptor inverse agonist. Basically, what the agonist does is it blocks the same receptor, but it has the opposite effect of an agonist. So the principal effects are mediated by a selective inhibition of the H1 receptors, and they have a moderate to high affinity for the histamine H1 receptors. They do not have muscarinic, serotonergic, dopaminergic, or non-adrenergic receptors. So they do not cause a dry mouth. They do not cause drowsiness, sedation, weakness. And that you typically see with levocetirizine or cetirizine. And it is supposed to have a limited distribution to the brain. And the affinity for the receptor is 3 to 6 times higher than cetirizine and fexofenadine. So it has a rapid absorption. It gets absorbed in an hour's time. And half time is 14.5 hours. And the best thing I like about bilastine is that it basically does not need to be reduced, the dosage for hepatic or renal impairment. So that is something that's very important, because fexofenadine has to be given with caution in patients with liver disease, especially. So it's non-sedative. It can be given once daily. Only the thing that you have to remember to tell your patient and give it to them in writing is take it 1 hour before food or 2 hours after food, because it doesn't get absorbed well with food. So if they take it right after food, it won't help them at all. So just remind your patient that they have to take it away from food. So, yeah, so that's about it about bilastine. And then bilastine montelukast, I'm sure sir will be speaking about it next. But it is, you can give it in patients who are having LRIs or low respiratory involvement. So the important thing is that they do not have cardiac, renal, or nervous system involvement with bilastine. So that's why it's pretty good. Intranasal antihistamines can also be used. They're very effective, but they can be given even alone 3 to 4 times a day. In combination, long-term, about 15 days is the recommended dose. But in children, I typically don't use it because of the bitter aftertaste, despite various companies telling you that, the taste gets marked. But always explain to your patient how to take it, bend forward, put 1 puff into each side of your nose, and not to pull it into your nose. Don't sniff it in, because that's what most parents tell the children. That's what causes that terrible taste in the throat. Leukotriene receptor agonists can be given as a step-up therapy. You must remember to step down after 6 weeks. That's the recommended dosage in combination with antihistamines. Dosage should not be more than 6 weeks, because it has some neuropsychiatric effects, including suicide. And I have seen a lot of doctors give montelukast levocetirizine combination. And for many, many years, I have seen patients with 7 to 10 years of daily montelukast with levocetirizine. And when they stop the medicine, the patients start having a crawling sensation in their skin. I've had multiple patients like this, so I usually tell the patients not to take it for long periods of time. You can add oral decongestant, especially for blocker patients. Local decongestant should be used with caution because, of course, they have their own set of side effects. Gel lath is a very good thing. If the patient is able to do it well, there are lots of ready-made preparations also available. Steam can be taken just before sleeping. Chromolomes I've not used much, and there's a new spray that's come around that's ipratropium, but I haven't used it personally, so I cannot say. And capsaicin spray is available according to theory, but I have never seen one. Oral steroids, if anybody is giving oral steroids for allergic rhinitis, please remember to use it for not more than 5 days. So allergic rhinitis, you have to step up the therapy as needed and step down when the patient gets better, and immunotherapy can be added. We'll go a little fast because I think I'm running out of time. So early detection of allergic rhinitis is very important because it helps prevent asthma. Various kinds of allergy testing are available, but the diagnosis, the choice is between skin prick test and a serum specific IgE test. But skin prick test is very sensitive. It's 98% sensitive, and serum, it measures the IgE that's bound to mast cells. So that's why it's very important that you do this. And it's the gold standard according to all the international organizations. And we should use blood testing only where the patient is unable to stop antihistamines for 2-3 days, whether it's a small child who's not able to undergo a skin prick test or a pregnant lady. Skin prick test is safe, it's quick, reliable, painless, repeatable, it's visible to the patient, and it's very economical compared to a properly done blood test. And it's very, very safe. So there's nothing to worry about SPTs. And I'm going to go a little fast because I want to reach the immunotherapy part. So the typically dust mites they are the commonest allergens. They are about 50% of the allergies are due to house dust mite, pollen 20 to 25%, molds, insects and animals. So animal, like I said, we have to tell patients about the environmental control, and mold are especially important in AFRS, allergic fungal rhinosinusitis. So in those patients, you have to consider the molds properly and give them immunotherapy for the same. So this is how your allergens look, and you can test it on the arm or the back, not both. So it's either on the arm or on the back. So this is how you do the test. You lift the skin gently in the arm, apply the medicine. You can do it on small children also comfortably. And the medicine is applied, pricked, a reading is taken in 15 minutes and noted in millimeters. The outcome includes allergen avoidance, medical management, and immunotherapy. So 9 foods are responsible for 90% of the food allergies. So if you avoid them, especially for urticaria and atopy, this is very, very useful. And allergen immunotherapy and allergen avoidance are the only 2 things that can modify the course of allergic disease. So it's, as an allergist, I would suggest that it's one of the good things in your armamentarium, and you should use it well. If you don't do it yourself, send it to somebody who does allergy work so that your patient can get better. So there are 2 kinds. One is allergy shots, that's subcutaneous immunotherapy. And then there's oral immunotherapy that is easier and there are less side effects. So FDA, it is less temperature sensitive. There are no side effects. There's no risk of anaphylaxis. So I find oral immunotherapy very, very effective, and it's easy to use, and it's very safe. So I've been doing allergy work for the last 21 years, and I find allergy very rewarding, especially for allergic rhinitis. 90% of the patients have stopped sneezing after a course of immunotherapy. And especially as new subset I have found is hyperreactive airway disease. The children who are on dust mite immunotherapy, they all get off the nebulizer. I have been treating them for about 7 years now. And these are the 70 children who have completed a 3-year course of, and they're all off medicines. So, and in asthma patients, the reduction in the amount of medicine needed and anti-allergics needed after immunotherapy is very significant. For nasal polyps, it reduces the need for revision surgery after almost 68% of our patients. And we have a 5-year follow-up of these. And in urticaria isolated, I use it, but experimentally, because I don't use it as a first choice. Coming to monsoons, there is excessive humidity. The temperatures are very high. And patients, especially children, remain indoor more of the time. They're not able to go to the park and go down for the outdoor activities. Upper respiratory infections increase, and we see a lot of allergic infective conjunctivitis, which all adds up to your symptoms. And because of the heat and humidity, your dust load, dust mites increase significantly. So all of these need to be treated. And we know that when pollution time, your intake of inhalers and increases, and nebulizer increases every Diwali. We have a lot of that. But in monsoons, you have a lot of upper respiratory infections which worsen your allergies. So you need to take care of your patients and increase the dosage as needed, and tell patients to take their bronchodilators and intranasal corticosteroids and inhaled corticosteroids aggressively. And dust mites will definitely increase. So patients can invest in a vacuum cleaner. They should ask to do that. And patients who can't, then they have to see whenever there is good sun, then they should put their mattress out in the sun. So the take home message is that allergy is treatable. And I don't want into 2023, if any patient says that allergy ka ilaj nahi hai, then that is something that makes me very sad, because as responsible doctors, we should ensure that the best of treatment is available for our patients, and we are able to treat all of them adequately. So if there are any questions, feel free to ask.
Thanks, Dr. Sarika, for such a brief and comprehensive lecture. I think the question will take after Dr. Rajesh's talk. So with this, I introduce Dr. Rajesh. He is a stalwart in pulmonology. He needs no introduction, but still, for the sake of doing it, as it is said, a good doctor is a one who not only treats the patient, but who does good research and contributes to evidence-based medicine. So Dr. Rajesh is a principal for the academic for clinical research. He's a well-known pulmonologist, the chief and the director at Getwell Hospital at Nagpur. He is the secretary of Indian Chest Society. He has multiple publications and has written chapters in respiratory book for the same. So with this, sir, I welcome you to take your talk.
Okay, thank you, Sunita. And after a nice introduction and also listening to Sarika's eloquent talk, we are on to what about asthma and URTA. And as monsoon happens, we do enjoy a cup of chai with also pakoda and also long drive. But there is also something else that comes when we talk about actually monsoon. And this is what I'm going to highlight a bit. I think the brief and the foundation of actually my talk has already been taken by Sarika. So I have got an easy task of what happens when we have this prevalence and how to manage actually URTA and asthma in monsoon. So as we know that we had a lot of deluge in the whole nation, in fact, and actually you're from Delhi. Actually, one of the speakers is from Delhi, so you know what really happened in Delhi, and also right now when I'm just taking this webinar, it's also pouring in Nagpur. So of course we got increasing rains actually during and all over India. It is spreading. So what happens is that after this rains and after this floods that happen, you have got also deluge of patients in your OPD, and post floods, you've got infections of the respiratory system, which are often among the leading cause of illness and death among survivors. We got causes of also respiratory infection. There is a loss of shelter. As you know, there is also what they call a displacement of people because of flooding, and as well as exposure to flood waters, which also can be a bit dirty, and of course a lot of rains. So we do have common diseases like patients have got allergic bronchitis, they have asthma, they have chronic obstructive pulmonary disease, and also pneumonia and viral influenza. All those make appearance with actually vengeance after the dry season that we have got in May, June. And also without also sufficient safeguards, actually the majority of them are also vulnerable to then also secondary bacterial infections. Hence, you have to also use some antibiotics. And it's very common that we got flu-like and upper respiratory tract symptoms such as cough, sore throat, and also rhinitis. and if they have been noted as a result of exposure to allergens or viral infection, as has been alluded by also Dr. Sarika in her previous talk. So it is a well-known fact that there is an association of major respiratory diagnosis with of course wetting in rain. And it is a common experience that patients who come to you with some infection or allergies or sick, they have got a history that they actually got wet actually during rains. And it has been proved beyond doubt by also the studies in which incidence of asthma, COPD, and respiratory infections have actually increased after being just wet in the rains, and rhinitis, urticaria, eczema increases the chances of asthma exacerbation because they're all just triggers for exacerbation. And if you analyze this also rain wetting, then even this later summer and beginning of monsoon, we have got dry season. And then of course, suddenly there is also a lot of also rains and also humidity. So marked with rains and also fluctuations in temperature, there's also changes in flora and fauna. There's also exposure of pollens, and of these may be responsible for the rise in respiratory illness during this period. And it has been said that, and it also happened during also COVID, that COPD in fact was quite low because people would stay indoors. But actually respiratory infections, of course, were associated with being actually wet in the rains. This is a well-known fact. And as also Dr. Sarika has just said that there is a correlation of allergic rhinitis and upper respiratory tract infections in the presence of an inflammatory disorder of the upper airways, actually also such as allergy. It would always predispose the patient to develop more frequent and more severe upper respiratory tract infection. So then what are the etiological agents that has been found to have in these patients if you just take a nasal swab or upper respiratory throat swab? And also bacterial isolates, they have been isolated are actually Streptococcus pyogenes, which is recorded the highest percentage as is our experience, which is followed by Staph aureus and also Moraxella catarrhalis. And also some of them are also Streptococcus pneumoniae, Klebsiella pneumoniae, and also Pseudomonas. They would go into for also bacterial infection. And then these are some of the dreaded infections that you fear that your patients can have if suppose fever is not going for about 5 to 7 days. And then you should investigate by also doing some sputum examination. So, and also there is a risk and other risk factors for RTI in of children is also reduction or lack of breastfeeding. There's a large family size and also school-age siblings. There's overcrowding and also school opens actually during this time. They also get exposed to other children having infection and then they would actually bring this infection to home, and elderly people in the home also get infected. It can also be because of parental smoking during pregnancy. It can be because of malnutrition. Also, vaccination plays an important part, and we always say that you should get vaccinated actually before the monsoon happens, or also colder season. Physical stress, intense physical exertion, climate and environmental factors, as happens during monsoon, dampness in the home environment, and also use of pacifiers. So these are some of the RTI infection children which they would get because of this predisposing factors. As has been alluded by also Dr. Sarika, symptoms of RTI are cough, cold, fever, and you have also chest tightness. So if you look at the management of upper respiratory infection in children, and this is a paper which was published, and we use actually much more of cough syrup. So this was a prescription pattern that was investigated in this paper from actually a single city. And what was found that instead of anything else, we actually depend on cough suppressant. And I'm not a very big fan of cough also syrup, in fact, except when it is happening at night and it's also disturbing your sleep. It is dry cough. But then these are the prescription patterns that we see. And this is another paper which was taken from Indore. And sad enough, the most common antibiotic prescribed was actually quinolones. And as actually a pulmonologist, I always want to educate my other friends that not to use quinolones because these are the drugs which are used in treatment of MDR TB. And hence, actually, please pay these as a group of molecules from your just a mundane infection or RTI infection, which you can travel. Best would be to use of a cefpodoxime, which is antibiotic, which you give for 5 days. If suppose you feel that there is also persistent fever and there is also yellow phlegm. But then in this study, it was much more quinolones, and then tetracycline, doxycycline, then comoxin was the most prescribed antibiotic for ear discharge. And adults with of course pneumonia, again, I actually find this very, very distressing that actually fluoxetine was used, because these patients, if you use also quinolones, they will mask actually tuberculosis if it is there in this patient, and they would get better, and then you would never know what they really had. So avoid quinolones for treatment of infections of RTI till the time that you are sure that it is not TB. There is also a pattern, also variation, if you see in teaching and non-teaching hospital, and it is a well-known fact that in private we use fancy antibiotics, while if it is teaching hospital, we would basically just rely on just cotrimazole as we had prescribed when we were also in the government hospital. Extended spectrum of penicillin and tetracycline works equally also better. But this is what is found when we just do a prescription audit of patients who have been prescribed these medicines. And this was a questionnaire, and in which I basically founded my inference that amoxicillinic acid remains the first-line antibiotic for actually URTI, although I would preferably cefpodoxime. Third generation cephalosporin were used for PU and uncomplicated typhoid infections during also summer. So this is what came out in the paper, as I have said, and I won't repeat again. Of course, we have to have some also supportive therapy, and of nutritional support is common to be given, and oral nutrition supplements, dietary counseling is effective for improving weight and also reducing the incidence of URTI, and also nutritionally at risk of peak eating children who have an acute URTI episode. A word or two about asthma, because this is what there is a lot of footfall of these patients, because they have experienced a dry spell during May and June when there is no summer, and then they don't suffer, and then suddenly you have a change in the atmosphere. There is rains. There is also a lot of humidity, which of course which increases, and most of these patients they stop their medications during the time, because they think that if they are okay, then there's no need to take the treatment. And then suddenly they are faced with this adverse weather conditions, and they come with exacerbations during period of time. At this point of time in my hospital, I've got about 6 or 7 patients who have just come with asthma aggravation, and also some of them in our ICU, and this is what we have every year, in fact. So why actually monsoon is a concern for asthma patients is because, as I said, there is an increase in humidity levels which can trigger asthma symptoms. The high moisture contained in the air can cause mold growth, which is a common asthma trigger. The increased rainfall actually can lead to an increase in pollen production, which is another common asthma trigger. And these combination of factors can make it difficult for asthma patients to breathe properly. And according to a study, which is an Indian study published in an Indian journal, there is actually a significant increase in hospital admission, as I said, due to asthma during monsoon season. And also the same study found that the number of hospital admissions for asthma increased by about 15% during asthma season compared to other seasons. And this highlights the importance of being prepared for monsoon as an asthma patient. So actually what I give advice, and what we should give advice to patients to prevent such exacerbation during monsoon. And it is very important to actually dwell on that factor, and we should tell the patient that even mild asthma patients can have exacerbation. It is not that patients who have got severe asthma would only have exacerbation. In fact, patient can go directly from having a mild asthma to acute exacerbation in these adverse conditions. Hence, they have to take their medicine. So We ask them to keep the inhalers handy at all times and make sure that they have enough of medications to last through the monsoon, because there's a flooding and they can't also visit the hospital. So I think maybe they can stock extra medication and also take inhalers regularly. Avoid going outside during peak hours when the air quality is poor, because air is not flowing, so air is just stagnant. So all those allergens are actually stagnant in the air. And if you must go outside, of course, wear two masks, as we have learned during the COVID times, because it also protects you from actually pollution, outdoor pollution. Keep your home clean and dry. Use a dehumidifier to reduce humidity if you can. If you have, also it was luxury, and also prevent mold growth, and clean air filters regularly to improve indoor air quality. We have to stay hydrated by drinking plenty of water. We just tend to decrease the water intake during these times, but it should be at least 10 to 12 glasses per day, especially for patients who are on asthma medications, and also antihistaminics, who have got dryness of mouth as a result of some of the side effects of these drugs. And then also when they don't drink much of water, even when the phlegm becomes a bit harder to expectorate. So I ask these patients to at least drink about 10 to 12 glasses of water. One should be aware of the triggers which are there, and try to avoid them as much as possible. And this common triggers during the monsoon include mold, pollen, and dust. And then we should monitor your symptoms closely. We've got home care devices which can monitor your asthma control, and then you can use what we call rescue or inhalers, which are to be taken during emergency, and you can increase their use. You can have a monitoring plan spelled out from your doctors. You can ask the doctors to have an emergency plan written for you, and which you can follow. And needless to say, the vaccinations form an important part of prevention of this URTI, as well as asthma exacerbation because of infection. And we have got basically availability of seasonal flu, and you have to increase the awareness and see that all your patients of allergy and asthma and other respiratory illness and other also chronic illnesses basically actually should get a flu shot every year. And this flu shot changes every year, in fact, because of the strains that they change, and it should be updated. There's also a very good vaccination for also pneumonia, which can be taken by these patients, and all of them are just more than 50 years old. So actually vaccination has got a larger the role to play, and we have to make patients aware about it. And of course, we should habitually prescribe it every year to them. So if I want to just actually summarize, actually the prevalence of allergic rhinitis and URTI increases in monsoon due to changes in temperature, exposure to air allergens and pollens. Enough children are majorly affected. Antibiotics, antipyretics, antihistamines, and as a combination with also mortality cost, and cough syrups. If you have cough, as also nuisance, and multivitamins, an important part. Allergic, the identification of allergic agent is necessary. Since URTI due to virus antibodies do not play any role, you should not give antibiotics to each and every patient of URTI who would just come to you. And about asthma, we should ask the patient to take their asthma medications regularly, and not just stop them when they don't have symptoms. This is what I would like to allude to all my patients, and just tell them and just caution them about this. So my experience about this monsoon illnesses is there that these patients, and I mean, especially as I told you that schools open actually during these times, and actually children get exposed to other children who are having basically this thing. And it's very good, as of course Sarika was telling, that actually there's an awareness among also school teachers, that actually they would point out to a child who has got cough or this thing, and ask him just not to come to the school. But of course it can overgo, as she had told, that some of the patients may have allergic rhinitis, and it can adversely affect their morals. In fact, if the teachers ask them for this. So I think that is my experience, and I think we should also use some home remedies. And I advise my patients that before you go for some antibiotics or some of medical prescriptions, try to take steam inhalations with some oil or something like, and then we've got availability of some oils like mint oil or this oil which actually can be put in which can be put in the water, and then they can steam and they can do steam inhale for 5 minutes in the morning, and I think 5 minutes before they go to the bed, and this really basically helps them a lot. You can get saline gargles for your throat irritations. You can have some tea, the warm tea with honey and some lemon. So all these actually home also remedies actually works almost equally as the cough syrups or the lozenges. So I think I would like to first, test these home remedies before you really go for antibiotics and also cough syrup. So, okay, thank you, and also thank you for your patient listening.
Thank you, sir, for such a nice and brief practical talk. Because the topic is very special, and I don't think we have ever had any webinar on this topic, allergies in monsoon. I have few slides where I will be discussing some practical points as per my experience. So, as rightly said by sir, that we have to treat the lower airways properly. Sarika has also highlighted this point. This is a slide by World Allergy Organization, and we all know the concept of one airway, one disease. So whether you are an ENT, chest physician, or a physician, if the patient has both the issues, if you treat one, the second will suffer. If the patient has AR, PND, if you don't treat it and you're just treating the asthma, the post-nasal drip itself will be a trigger for cough. So I think whenever such a patient comes, Sarika very nicely said that please, as an ENT also, you should auscultate all the chest of all the patient. So I think always see both the aspect, because the nose is only a gateway to the lungs. And if the patient has other comorbidity, please try to treat that. Sir, any opinion of my speakers on this, or we can continue?
Yeah, we can continue. So as you said that we should, ENT should have stethoscope. I think I would also ask pulmonologists to see for allergic rhinitis problems, and then you'd also co-treat it.
Thank you. So these are the house dust mites. Sarika has already said all the avoidance. One quick tip is that, for example, in Mumbai, we have not seen sunlight in the last 7 to 10 days. It is raining so heavily. So in such cases, patient has what to do during this monsoon season. So best thing is to put all your mattress and the bed sheets and the pillow covers and all in hot water, so that these dust mite and their particles they die away. And if sunlight is there, please put it in the sunlight later on. Nowadays, we have very good washing machine with all the allergy care instructions also. So this is one of the thing. And also before the monsoon season, if you know you have dust mite allergies, please do all the avoidance measures as already given by your doctor or allergy specialist. For fungus, everyone thinks fungus is only inside the house, in the bathroom, kitchen and all, but always see the plants which you have in your balconies. We all are in cities with the short spaces, and these soil are the soil and the leaves, they also has fungus. So please take a note of it and do the avoidance accordingly. The pollens, it can be as Dr. Rajesh already said, you should know how to avoid pollens, but many of the time this becomes very difficult. Two clinical aspect, whenever you go out, please roll up the windows of your car. And second thing, when a patient comes home from outside, he should take a shower with the headband, so that these pollens do not stick onto the sofa or the bed, whichever the patient will use. If he doesn't do that, these pollens will be in constant touch with him throughout the night for a period of 8 to 10 hours and will aggravate the allergies. This is a very new thing in India, though this was discovered a few years back in Australia and then Dubai. This is called as thunderstorm asthma. Sir, would you like to highlight something on this?
Yeah, so these are the conditions when you have thunderstorm or the tornadoes that we call. So they will actually, start and they will end up somewhere, and they will travel along a distance. And these thunderstorms typically will have actually grass also pollens among them. So and then it is carried across the area, and also because of the exposure of this dust along with I think pollens which are the grass pollens, you have an increase of asthma exacerbations in this population where this where this was there, in fact, and the way it has traveled. So it was first discovered in Australia. It's quite common in Kuwait and also Saudi Arabia, where there is also sandstorm which starts and you cannot see anywhere, and it just carries dust. And then after that, you got surge of asthma exacerbation.
Right. So the thing is, when these fragments go into the cloud in the moisture, they absorb it and they burst and causing all the nanoparticles, and that is how they reach the lower airway. And that's why I think today sir has so many patients in the OPD, because there was so much of rains and thunder over there. And the only thing is to prevent is to take inhalers properly. We all are very much aware of that. Sir has already said it. Sir, any comment on the peak flow meter and how it can help our patients on a daily basis in this monsoon when they can't come and visit us in the hospital?
Yeah, so I think, as I said, that I think all asthma patients should ask for an emergency medication plan for their asthma, because they can't visit actually doctors during this season. And typically we actually give them this peak flow meter, which is also called as what they call breathometer. And here, for each and every patient, when they take this, we just give them their value depending on their age, height, and sex. And then we ask them to have this green and also yellow and red, zones which are marked for them on their own personalized peak flow meters. And we ask them to be cautious enough. If suppose they would just fall into a yellow zone, they should start taking a medication which would actually just what to call rescue them from them. So we've got an emergency inhaler which is always given to them, and I think they should use it. And of course, as I said, during this time, they should keep their home very clean, and maybe use of some indoor air also purifiers if you can afford. All this thing helps.
Thank you, sir. So I think the color coding of the zone is very important, and you can teach your patient, you can tell them what is their safety zone, and they can monitor themselves. Tell them not to reach the red zone directly. Whenever they see a yellow zone, start taking your inhalers also. There are many myths and facts about these inhalers. As doctors, we should try to make our patient aware that these are not additive. We all know what are these issues. Patient wants to get relief of them. Please try to explain them and educate them about it, because these are the only things which will prevent deterioration in the monsoon season. Always check the inhaler technique, what the patient is using. There is a study by Dr. Salvi that shows that 95% of the doctors and paramedicals also don't know the proper inhaler technique unless they are taught about it. So please learn the right technique, spread the word, and teach your patients also the right technique. Many times we see that though the patient has respiratory allergies, he comes with many other type of allergies, and that is the multiple allergy syndrome. And with this, the patient, we should always treat them. And many times we need the help of biologicals. We did not cover this in our lecture, but if required, we can talk about it later on also. With this, I can just show some examples of how the biologicals help our patient. These are true for multiple allergy syndrome, in severe urticaria, and also in severe asthma. This is a chronic rhinosinusitis patient with a nasal polyp where the biologicals had helped. The patient was already operated 3 times, and this time he refused surgery, and we gave him this option along with immunotherapy. These are few cases of skin allergy which can aggravate during monsoon. I have seen even dust mite causing pure angioedema, where if given a dust mite immunotherapy, the angioedema also resolves. That was the few cases which Sarika was saying, that if urticaria, if you can correlate the history, you can go for immunotherapy. Atopic dermatitis improving with immunotherapy. Food allergy, they can be nuisance during monsoon because we eat so much of outside food which is contaminated. One word which I would like to say, that whenever a patient of anaphylaxis reaches the casualty, everyone gives only Avil and Foracort. The treatment for anaphylaxis is adrenaline and adrenaline, add adrenaline. So please see to it you give adrenaline to such patients. Even if it's a cardiac patient, don't hesitate, give adrenaline. It will save the life of the patient in anaphylaxis. Antihistaminics are not a treatment for anaphylaxis. So this is our study of biologicals. Always educate your patient about everything. Take time for that. Make a proper treatment plan. Make a holistic approach. Educate the patients about all the allergies, because every time it becomes very difficult to tell the patient about each and everything. Make some YouTube videos when the patient is waiting in your clinic. Let them listen to it. Let them come up with the doubts. The more you explain it to the patient, the better quality of life the patient will have. And always, if the patient say the inhalers or the nasal sprays are not helping me, please check the technique and the compliance of the patient. Most of the time, that is a problem. So the learning point from us, we have already discussed, but at the end, I would like to state that allergy and immunotherapy is the only disease modulating treatment in allergies, which can change the allergic milieu to a non-allergic one. With this, we stop here and we start the questions put forth by our audience. Dr. Sarika, what's the role of oxymetazoline and azelastrine? Which one to use?
Oxymetazoline can be used in nasal blockers, but very, very occasionally. As you all know, oxymetazoline is habit forming and it can cause rhinitis medicamentosa. We see patients who develop dependence, so we should use it with great caution. I personally don't use it at all unless it is a otitis media with effusion, and I always give it in writing not to be taken more than 3 to 5 days. What happens is it causes such an immediate relief that the turbinate shrinks so quickly that the patients get addicted, and then they don't feel that same relief coming with your nasals, the fluticasone or mometasone. So that's why the patient dependence happens very quickly with oxymetazoline. So I prefer not to use it at all, because allergic rhinitis is a long-term disease. एक दो दिन की बात नहीं, it's a long-term thing. Azelastrine is a good molecule. It works very well. It acts really quickly. Within few minutes, the patient gets relief. But the only thing it's a bitter molecule. And in acute patients, you can take it even up to 3 to 4 times a day, like a rescue medicine. But usually it doesn't cause dependence because of its bitterness. The patient is able to get off it very quickly.
So for how many days you use azelastrine?
I tell the patient in an acute phase that you can take it even every 2 hours. One puff each side of the nose, but up to 3 to 5 days. And then, of course, long term, if you're giving a combination with fluticasone furoate, then you should give it not more than 15 days. And as you would have noticed, all your packages of these combined drugs, they come with a lesser dosage compared to fluticasone furoate or mometasone alone.
Yeah, thank you. What is your experience with clinical overlap of AR with asthma? Do you see?
You want me to answer that?
Any one of you?
Dr. Rajesh Bariya.
Yeah, so it's very common, in fact. So as I was telling that in my practice, if you ask and if you ask the papers, it's about 40 to 60% of patients of asthma will have comorbid condition as allergic rhinitis, and you should always find these things, and you have to treat both, in fact, to have, I think, complete relief of his symptoms. So it's very common.
Are antihistaminics with montelukast combination helpful in asthma?
Yeah, so only indication of giving montelukast with antihistamines in asthma is when you have asthma and allergy both in those patients, allergic rhinitis both in those patients. What I have found is that patient gets hooked to this montelukast and antihistaminic combinations, even if you give it for not more than 3 months. I think there are studies in which you can give it up to 6 months, but I have seen people hooked to it for years together. And here I think a word of caution, because for montelukast you got a black box warning from the US FDA, and also especially for children who had just developed some psychological problems when they were put on montelukast for a longer period of time. I think this was actually a Canadian study which was so hence after the study there is actually what you call a black box warning for but I think and also you would also agree, both of you would agree, that our patients just take it for years together.
Yes,
without
yes.
any problem.
Absolutely. We used to see that very often, but now with this black box warning, I think we all should be careful and use it only for a limited time period, and that also in proper indication.
Yeah.
Yeah. Sarika, what's the age? Is it safe to start fluticasone nasal spray in children?
So usually they say 2 years, but for children below 6, I usually use mometazone. And in fact, till the age of 12, I prefer to use mometazone. And for about 12, I give fluticasone furoate.
Okay. So what precaution we can ask our patient to take during monsoon? I think we have discussed this in detail regarding the allergens also and the medicines also. Any specific treatment plan for AR in patient with comorbidity like renal or hepatic impairment or having diabetes?
With diabetes, you have to ensure that they don't take oral steroids for sure. And if you're going to give immunotherapy, especially oral immunotherapy, it is glycerin based. Even though it's just few drops, I think it's not a bad idea to get a good check on your sugars and ensure more than, I don't think allergic rhinitis has that much of an impact on diabetes, but you have to ensure that they walk adequately and do their regular exercise, breathing exercise, so that improves the overall quality of life. And with the renal failure, you should not give medicines like fexofenadine because obviously they are not going to be able to take them well. Also for cardiac patients with acute interval can be. So you have to monitor the dosage and ensure that they're, and I usually tell the patient, you can go back to your treating physician, primary care giver, and tell them this is what the doctors advise, so that we work as a team and not in isolation, so the patient doesn't get confused. Iska baat follow karna hai, iska baat follow karna hai. I always act as the specialist. I give this thing, but I always tell the primary caregiver to be the final judge.
And I think here is the role of Bilastine very important. Within patient who have comorbidities, elderly patient, Bilastine really works well. And in my experience, I have not seen any effect of side effects of Bilastine as of now, and patients have used it for long term also. I hope both the speakers will agree to the safety of Bilastine for that.
Yeah, Bilastine has really changed actually scenario. In fact, the only I think the thing is that it's to take an empty stomach. So that is one word of I think caution that you should give to your patients and ask them to take it empty stomach. Yeah. Otherwise, it has changed the way that actually we used to look at and test the combinations.
Yeah. So just to reinstate the fact which Sarika was taking, please take Bilastine on an empty stomach 1 hour before food or 2 hours after food. Otherwise, 30% of the efficacy is decreased. And also, it should not be taken with grape juice or alcohol. That is also important factor. Otherwise, patient usually have it with juices also. So please try to avoid that.
I think that no drug should be taken with alcohol, I think, for that matter.
So please help us with the management plan for AR and asthma in children. When to prescribe oral and nasal antihistaminics? Sir, for you.
Okay, for me or for Sarika, that's for nasal congestion, na?
No, so AR and asthma in children. So any one of you can take it.
So yeah, ideally medical management is a good option. And if the patient remains fine and they have intermittent symptoms, medical management, intranasal corticosteroid with antihistamines is a good option. But if the patient is having hyperreactive airway disease or they're needing nebulizers for a long period of time, then it's always a good idea to go in for a skin prick test. And if they have house dust mite or pollen allergy, you treat it with immunotherapy so that the patient doesn't need medication for prolonged periods of time and their allergies get resolved and their quality of life improves.
Yeah. So I think in allergies, because allergy is actually a systemic disease and multiple organs can be involved and systems can be involved. So if you are an ENT person, you can manage AR, but not asthma. Please take the help of your pulmonologist friend, pediatrician, skin specialist. We should all work as a team because it becomes very difficult for a specialist to manage the other organs. So that's why the awareness that all this multiple allergy syndrome can happen in one patient, see the patient as a whole, and please refer to the other specialist colleagues also.
Because it has been my experience that these actually some of these people also have got nasal polyps, right? And then we just continue to treat them as only allergies. And so I think you should look at the symptoms. If they've got some blood stains in their sneezing, or I think we should go for FES and then IIS who have got nasal polyps to at least get, I think, a nasal endoscopy done, actually before you give these things for a longer period of time. So I think that is also a word of caution for, I think, all, for us as pulmonologists, in fact.
Yes, sir, absolutely. Is there any role of oral antihistaminics URTI? I think yes, for short
Yeah,
term.
because they
everyone
reduce
uses
the
it.
symptoms, no? And they improve the quality of life. Nasal congestion, watery discharge, all of that settles down.
So we have to understand URTI during monsoon is very normal. Everyone of us will have it once in a while in that 3 months. But you have to differentiate an acute URTI from a chronic allergy patient. And in that, how to manage what pharmacotherapy, Sarika has already said about it, Sir has talked about it. So I think that is how we have to take it forward from there. Use of corticosteroid in asthma and AR. We have already talked about it. Most of it is topical steroid, whether it is a nasal spray or an inhaler, and the role you can't underestimate. And I think the reason for this is that somewhere the respiratory allergies are basically inflammation, and the steroids are best to take care of the inflammation. And as Sir rightly said, that these things increase in the monsoon because people stop using the inhalers, and then they worsen during the monsoon season because of those various factors which has already mentioned. So any role of immunotherapy in reversing airway modeling?
So airway remodeling is not affected by immunotherapy. It's only what do you call it, inhale corticosteroids that would actually reverse the airway modeling, because it is all because of untreated inflammation, which increases the collagens in these patients, and then it will cause airway modeling. But I think patients of asthma who have got allergic rhinitis and have got persistent symptoms, I think I would go for a skin prick test and see if I can help them by immunotherapy. And most of these patients, if you don't select these patients carefully, and also actually go for immunotherapy if it's indicated, and also especially for dust mites, I think the results are fantastic.
Absolutely. We are out of time. One last question, because I think this is really important. Considering that immunotherapy has shown benefit in asthma, can we see immunotherapy in asthma guidelines soon? Sir, your comment.
So I think guidelines are already there. It's not, and it's there since I think 10 years or so. I think GINA 2012 or 13 had actually, for the first time, they said that there is a role of allergy testing and immunotherapy, especially in patients who are on high dose inhaled corticosteroids and who have got also allergic rhinitis with them. So I think it is actually a well-established fact if it's there in GINA guidelines. And I think most of the national guidelines, actually, they would tell you whom to pick up for this allergy testing. And
I agree with Sir. Please refer the GINA guidelines, and you will say from step 3, 4, 5 onward, they say use immunotherapy for dust mite. In ARIA guidelines for allergic rhinitis, we have that also in moderate persistent thing. You can refer Euphoria guidelines, EPOS guidelines, everywhere immunotherapy has been added to all.
Also AOI guidelines for allergic rhinitis, we wrote it last year. That was also, we mentioned immunotherapy as a very prominent part of our long-term control.
Guidelines from the ENT Association. So if anyone wants any details about these things, you can please write email to us or just be in touch with us. We can provide all the scientific data for it. So with this, we end our beautiful webinar. I thank McLeod's for giving us this platform for such a good scientific discussion. I thank my esteemed speaker for the same. It was nice interaction with you. And I thank all my audience for taking out time in this evening session for monsoon in allergies. Thank you. Enjoy the monsoon and enjoy your tea and pakoda as said by Raj, sir.
Thank you. Thank you, sir.
Thank you, ma'am. Thank you, sir, for your valuable insights today. And definitely these insights will be helpful to all the doctors in the audience for their management of patients suffering from allergic rhinitis, asthma, or upper respiratory tract infections. Thank you, sir. Thank you, ma'am. We'll definitely looking forward to have more such interesting sessions in future as well.
Thank you.
Thank you. Take care. Bye-bye.
Thank you. Bye.
Yeah. So with your permission, shall I conclude this meeting, sir?
Yes, Himanshu.
Yeah. Thank you very much. Thank you. So from here, I'm ending this meeting. Thank you very much, everyone.
Thank you, ma'am.
Yeah, thank you. You stopped the relay.